Good afternoon, everyone. It's Friday, July 17th, and time for another community conversation event hosted by the County of Marin and Marin Health and Human Services. I'm Lainey Hendricks, Public Information Officer for the County of Marin, and I will be your moderator this afternoon. The purpose of today's event is to review recent COVID-19 activity and related actions, including new directives from the state of California. We'll also discuss some of the outbreaks that we are experiencing here in Marin County and what's being done to address those. As a reminder, you can find the latest information about COVID-19 activity in Marin by visiting coronavirus.marinhhs.org. On that website, you can also subscribe to receive daily status updates, which contain an overview of confirmed case data and other updates about Marin's response to the COVID-19 pandemic. To receive those updates by email, visit coronavirus.marinhhs.org/subscribe. Or to receive updates by text message, text the phrase Marin COVID to 468-311. Well, today we have an excellent lineup of panelists joining us today, and I'd like to introduce them to you now. First is Dr. Matt Willis, Marin's Public Health Officer and visible leader throughout this COVID-19 pandemic. We'd also like to welcome back Angela Nicholson, Director of Marin's Emergency Operations Center. Today, we're also fortunate to have two guests representing our local healthcare system, which are also partners in so many aspects of the COVID-19 response here in Marin County. First is Dr. David Miller, an infectious disease practitioner at Kaiser Permanente in San Rafael and program lead for Kaiser's Community Readiness Collaborative. Welcome, Dr. Miller. And we also have with us Dr. Elizabeth Lowe, Medical Director for MarinHealth's Mobile Care Unit and Medical Director of Ambulatory Primary Care at MarinHealth Medical Center. Welcome, Dr. Lowe. Our format this afternoon is we will start with an update with Dr. Willis regarding COVID-19 activity here in Marin County. And then we'll hear a bit more from our other panelists before we dive into some of the questions that were submitted by viewers earlier this week. So with that, I'm going to hand it over to Dr. Willis to get us started. Dr. Willis?
Thank you, Lainey. Good afternoon, everyone. It's been an active week in our response to the COVID-19 pandemic here in Marin and across the state. So we appreciate this time to touch base with you all in our community and offer an update and also give you a chance to get to know some of our partners, some of our valued colleagues kind of that have been on the front lines with us throughout. And this is something that we'll continue to do in our updates ongoing, is to really start bringing in some of those diverse voices from across the community that have been such an important part of our response. So I'm valuing both Dr. Miller and Dr. Lowe for joining us today. Can I have the first slide, Jason? Thank you. So here's our update. Next slide, please. And this is again just to orient us. Each time we'll be reorienting ourselves to the fundamental values that we're applying to our response here, recognizing that while we address the COVID-19 pandemic, we recognize that it's happening in a more holistic understanding of health, not simply the prevention of COVID-19 disease, but reconciling and balancing that with other values, including mental and physical well-being. And this is the World Health Organization definition of health that we in the Public Health Department really apply to our approach to well-being. It's a state of complete physical, mental, and social well-being, not merely the absence of disease. Next slide, please. Just want to call your attention to a new feature on our website. We've gotten a lot of interest in the data that we're presenting to you all, and anyone is invited to come and join our website and observe all the data that we're updating. It's usually updated about 4 o'clock each afternoon. And we keep adding as we get more numbers and more refined analyses, adding more data to the website. And this is the new look and feel of our website that can be found at coronavirus.marinhhs.org. Next. These are some screenshots from that website just to offer the basic update. We've tested over 40,000 people now in Marin. Are testing, between 600 to 800 daily. We've had 2,015 cases. We have had a total of 85 individuals hospitalized, and our number of deaths has increased to 29. Our total percent positive rate across the board is 5%, and I'll talk more about that in a bit. We've separated out the San Quentin experience because it's been such a dramatic and rapid increase in cases in that particular community. There's been over 2,000 inmates who have been infected and over 200 staff, with 1,200 active cases in that community, with 12 deaths in San Quentin inmates. We have 29 people currently hospitalized in Marin County for COVID-19, 7 among San Quentin inmates and 22 among the rest of the community. Next slide, please. This is the curve that shows the number of cases we've had over time since the beginning of the pandemic. Obviously, this is summative, and each day there's more cases, so this would increase. But what we're seeing importantly here is that the slope itself is increasing. So the number of new cases increases significantly, especially since about mid-June, we started seeing a more rapid increase. But importantly, that bottom yellow line is our total hospitalizations, which has been remained relatively stable. Next slide, please. This is an important thing that we look at each day, which is the total percent positive tests. And that's been increased slightly since mid-June again, but has been relatively stable since then. And this is the way we distinguish between when we see increased cases, whether or not it might just be related to more testing versus more transmission. And because we've seen an increase while we've seen more testing, we know that we're actually seeing more virus transmission in our community. Next slide, please. This is the age breakdown. I just want to call your attention to 2 factors here: the youngest age group and the largest and the oldest age group. So for the youngest, that's the tan color, makes up on the far left there about 21% of our population, about 15% of our cases, but only 4% of our hospitalizations and none of our deaths. And this is important for ongoing conversations about how we might approach schools. These are school-age children from 0 to 18. And then on the other end of the age spectrum, the blue color, that light blue representing people above age 65 and older, we see that it's about 21% of our population, but 95% of our deaths are in people above that age. And if we go even further up, from age 80 and above, it's about 5% of our population, but about 70% of our total deaths, which is, what consistent with national and international experience of the much higher vulnerability for people in older ages. And Dave will talk about that a bit when he talks about our response to outbreaks in skilled nursing facilities. Next, please. This is the current age, the distribution by race, ethnicity in our population. And it's important to note that while on the far left, people who identify when they test as being Hispanic or Latino in terms of their own race, ethnicity, make up only 16% of our population, but a full 78% of our cases. And that's really been an important characteristic of our particular experience of this pandemic here in Marin County. Next. So here are the summary of the key changes this week. We've seen a significant increase in our cases statewide, regionally, and in Marin. And nationally, it's COVID-19 is surging. Our hospitalizations are elevated, but have been steady. We've had outbreaks, an increasing number of outbreaks in our long-term care facilities. And again, Dr. Miller will address that more specifically. On July 10th, a field hospital was established at San Quentin Prison. I talked about this last week. Obviously a large outbreak there. The county helped summon resources from the state to respond to that crisis. Fortunately now with that field hospital, it's called an alternate care site. There are now fewer transfers to regional hospitals. There are now 100, actually, that's just been updated, over 100 inmates currently in that 200-bed facility. And that's allowed hospitals throughout the region to return patients who are inmates at San Quentin who are well enough to be returned to that facility. On July 13th, based on our status as being on the state monitoring list, which is that we are one of now 32 counties in the state of California that are being specially monitored by the state based on increased incidence. The vast majority of state residents live in counties that are on the monitoring list currently. And we were obliged by the state to close non-essential indoor businesses, hair salons, barbershops, and indoor malls on Monday based on that status. On July 15th, Public Health worked with Marin County Office of Education to recommend deferring in-classroom learning until after Labor Day. In mid-June, we had made a recommendation that we would do everything we could to return to full-time in-classroom learning, recognizing that that was really best for kids and best for learning and the social development, and that the distance learning had been a negative experience for so many and differentially experienced, especially by income across our community. However, unfortunately, due to what I've just described in terms of evidence of increased transmission, the risk benefit shifted, and we had to make an unfortunate decision to decide to delay that and work to decrease our incidence before we could really return to full in classroom based learning. And then earlier today at noon, the governor announced that counties on the monitoring list may not open schools until they are at least 2 weeks off of the monitoring list. And so that's an important organizer for us as a community, is to work to reduce our incidence so that we can achieve that status of being off of the monitoring list based on our incidence, so that we can resume what we had hoped to do with regards to schools. Next slide, please. These are the counties on the state monitoring list. Actually, Santa Clara is now, and San Francisco are both, so this is a little out of date. Virtually all Bay Area counties are on the list now. And the most important, and on the upper right there, it shows the criteria for being on the monitoring list. For us, the most important is that the case rate of greater than 100 per 100,000 over the past 2 weeks is the indicator that we are far above that. We're about 230 per 100,000 in the past 2 weeks. So that's where that's going to be what we're looking at most closely as we try and achieve that goal of falling off of the monitoring list. Next, please. There's the list of all the counties on the state monitoring list. Next, please. This just shows what's happening across the state of California in terms of the surge, really starting in kind of late June, increases in people coming into hospitals there on the left, and increase in people being admitted into ICUs on the right. So this is part of a statewide experience. Next, please. So these are ways to, I've gone through some obviously really important issues and themes for us and there's a lot more. I know there's a lot of questions that will be related to those, and we share a value of just trying to make sure that we're communicating very clearly with our community and keeping you up to date. And so in addition to these kinds of forums, there's other ways to stay engaged. One is at our website. We've already mentioned the website. On there, you can go for testing information. You can get links to our data. There's also an ever-growing list of frequently asked questions. So as questions come up, whether it's by email or other, we will compile those that are, in terms of themes, and then post answers to that. And that's searchable. So if you have a question that has a keyword or a search, you can type that in, and hopefully you'll be able to get your answer that way. And then we do daily status updates. Sometimes I or one of my colleagues will do, a video update just to illustrate a theme or a concept that or a challenge that we're experiencing. And you can see those into your inbox, your email, if you sign up for those every day. And then obviously, following us on social media, Facebook, Twitter, and Nextdoor. Next, please. And now I'll hand it over to my friend and colleague, Angela Nicholson. Angela is with the County Administrator's Office, Assistant County Administrator, and will talk to us about some of the progress we're making in enforcement.
Good afternoon, everybody. On Friday of last implemented a shelter-in-place violation inbox. So if you want to report a shelter-in-place from a violation by a business, please email us at sipviolation@marincounty.org. This isn't the email box to report people walking down the street not wearing masks, as it will be enforced by a task force, which I'll talk about in a little bit, but this is really about business violations. There is a California strike team, state strike team, and it's made up of agencies like the CHP and the Cosmetology Board and the Alcohol Board, and they are moving around the state and especially focusing on areas that are on the watch list. So I know that they have enforced in counties around the Bay Area. I'm not certain about the enforcement here in Marin yet, but they are watching for enforcement violations around the state. In addition, over the last few days, we've put together a Marin task force. At our board meeting on Tuesday, we will be seeking an ordinance to put administrative fines in place for non-compliance with the shelter-in-place order. We will enforce for businesses through a joint task force. That's a task force combined of county employees and also the cities and towns, looking at making sure that, number one, we educate people because we're really seeking behavior change. Given the data that Dr. Willis just went over, our goal is that people need to be following the shelter-in-place order so we can stop the increase of incidents in our community. So our focus will be education and behavior change in the interest of public health. We will really utilize jurisdictional discretion to focus on enforcement of the greatest risks. So every email that comes into that box will not necessarily get immediate follow-up, but we will be looking at for consistency and making sure that we are in the places that we need to be to protect people the most. So I'm happy to talk about enforcement, but we're excited to be getting off the ground this week. Lainey, I think I'm turning it back over to you.
That's actually back over to Matt, I believe.
Oh, back over to Matt. Okay.
Or maybe Dr. Willis, maybe we have a connection.
Next slide. I think it's my go ahead. Next slide there, Jason. And I'm just gonna I think hand it off from here to Dr. Miller for his presentation, and it'll be part of this slide presentation following mine. So Jason, if you could just bring up those slides, we'll continue into Dave Miller's presentation, and then hand it off to Dr. Lowe.
So while Jason's bringing up those slides, did you have any closing comments you wanted to go ahead and add, Dr. Willis? If I remember correctly, it's an inspirational one.
Next slide, please. I think it's just the slide. There we go. That's the message. Thank you, and we can do it. That's my 10-year-old at the Rosie the Riveter Museum. Reminding us that there's how much we can accomplish when we stand together, I think we all recognize that this is a really challenging time for all of us. We were so successful when we first came together to flatten the curve, and now we're seeing the consequences of as we reopen, and if we are too casual and too relaxed in our behaviors as we move forward. I know all of us are tired of this. People are growing increasingly impatient, bored, missing their friends, missing social interactions. Unfortunately, the virus is on a different timeline. And the virus is teaching us that we don't really have the luxury of doing those things yet. And we need to move back much closer to the way we had been living in these, when we were so successful again in the earlier chapter of the shelter in place in March. And we know that we can do it because we did it, and we're going to need to continue to do that and do that again. And I'll hand it over to Dr. Miller now.
Thank you for that presentation, Dr. Willis, and Dr. Miller, go ahead and take it away.
All right, thank you guys. So I'm going to talk a little bit about us as community partners addressing the long-term care facilities in Marin. Next slide, please. So we all know how to slow transmission of COVID-19 virus essentially by protecting ourselves, by practicing social distancing, masking, and hand hygiene. and much of the county is still doing a very good job. Next slide. Of course, implementing these techniques are less feasible where people are living and working in denser areas. For example, out here, it's very easy to implement social distancing. Next slide. But what if you're living with someone who's positive? It becomes a bit more challenging. Next slide. Or let's say you're living with multiple people. Next slide. Or in very dense living situations, such as San Quentin. So as an ID doc, I look at the community for social structures that facilitate increased viral transmission and outbreaks. Next slide. And so all of you are aware of the toll the pandemic has taken on the long-term care facilities across the globe. This has been heavily publicized and rightfully so. And as community partners, we've all recognized this concern, and we did so very early in the pandemic in this county. And when we think about these congregate settings, we need to think about two populations. One is the residents who are older with multiple medical problems, living densely. This is a high-risk, vulnerable population. But there's one more, and that's the caregivers who provide high-touch and therefore high-risk essential work to the care of these residents. So we knew that we needed to send clinicians out to these facilities. We knew that we needed to tend to these residents directly, provide testing, but also to send out support teams for the residential care facility workers and to support their operations to help keep these workers safe too. Now, this is a pretty formidable challenge. There's of just the residential care facilities for the elderly, there are 55 in Marin County, and they care for 1,700 residents. There's also 13 skilled nursing facilities, which care for 1,000 residents. These are a little different types of buildings. Next slide. So we realized that we really needed to innovate, and because of the scope and complexity, this required partnerships with MarinHealth, Marin County Department of Public Health, and the residential care facilities themselves. It was an all hands on deck situation, and we created something that we now call the Community Readiness Collaborative.
And Dave,
next slide.
Dave, can I just point that must have been early days, right? Before we were requiring people cover their faces.
That's true, actually.
Thanks for just wanted to point that out.
It's a perspective issue. They're probably about 4 feet. You got me there. Okay, well then let's go to the next slide already. So this is some symbolic letterhead of us joining forces with MarinHealth, Kaiser Permanente, and the county Department of Public Health. And this was us joining forces and offering support to the residential care facilities. So each partner really brought their own organizational strengths. Because at Kaiser, we work with an integrated model. We're able to pull together an interdisciplinary team with all the necessary specialties that were required to meet these challenges. And this is pretty vast when you think about the nature of the problem. You have infectious disease practitioners, geriatricians, general practitioners, you need administrators, data analysts, health educators, and more. Next slide. Additionally, we use our large hospital network and all the county data that we've linked together with, and we contact trace cases back to residential care facilities and skilled nursing facilities. So this is actually relatively somewhat unique and definitely more advanced than other counties. And so once we've detected an outbreak or an exposure to a facility, we then tend to it. And we do that as a team, as a group. And how do we do this? This is a virus where you can have few symptoms or no symptoms at all. So we really need to do, what we do is we do these mass testing events where we test all the staff and all the residents. These are large populations. And we do that repeatedly every 7 days. When we have an infected staff member, they don't come back to work until they're cleared. If we have a resident, we make sure that they're isolated safely, that the people caring for them have sufficient supply and technique. Next slide. With all of this, we're confident that we have flattened the curve, at least contributed to flattening the curve. We've stewarded more than 8 outbreaks to completion. We should be very proud of this program in Marin. It's taken a lot of innovation from all the partners, including the County Department of Public Health, with many unique health orders to support this work. This is an article that was published in the June issue of San Francisco Marin Medical Society Journal, highlighting our work and systems that were innovated right here in Marin County. Next slide. However, as Dr. Willis mentioned, there's many challenges that lay ahead. And with the rise in cases that we're experiencing in our essential work populations, we're seeing that in our residential care facilities and our skilled nursing facilities where these many essential workers work. Right now, there are 33 residential care facilities in active testing cycles and 4 skilled nursing facilities. So we've done a lot of good work, and this is an evolving situation. We've tested thousands of patients. We've diagnosed 252 staff members of these facilities and 203 residents. Unfortunately, there have been 23 deaths, which Dr. Willis pointed out makes up the vast majority of cases in Marin County. So all this to say, we need to continue, we are continuing to be vigilant and proactive to adapt to this dynamic situation. Next slide, please. This is our team here in the early days where we were masked, actually. And in the middle is Liz Lowe, who's going to go next. The guy in the back is me with the blue shirt. And Lael's in front with the County Department of Public Health in gray, and there's some representatives of our residential care facility that we were visiting at that time. So in summary, this virus really respects no institutional boundaries, and we need to work together to fare the best possible in this crisis. Thank you.
Thank you so much, Dr. Miller. That was really, really informative, especially all the great work, proactive work, I should add, that's going into coming alongside our long-term care and skilled nursing facilities. So critical, not only in testing, but helping those institutions themselves understand how to proactively spot the disease and react to it. Okay, so now we are going to transition over to Dr. Lowe, who we're very excited to have with us as well. And just one moment. Sorry, we're doing a quick technical swap for our sign language interpreters. All right. So Dr. Lowe, I understand that you have been working with our testing team. Actually, you've been working with our team today, right? Are you at a testing site right now?
I have just pulled up into the Civic Center. We were just testing in the canal.
Oh, wow. Excellent. Great. Well, since you could say it's fresh on your mind, would you like to begin by walking our team through what a typical day looks like with our mobile testing team that you're a part of, and maybe tell a little bit more about what your specific role is with that testing team?
Sure. So I'm the medical director of our mobile care unit. We originally had a fixed clinic that's up in Nevada with MarinHealth, where we were testing for COVID positive patients. And we realized after about 3 weeks, we didn't have as many people showing up to our testing clinic. And we realized it was because the people who were in residential care facilities or in high risk areas who were not showing up to be tested or couldn't get up to Nevada to get tested. And we needed to go to them and provide that service to them. Some of them didn't have cars. Some of them didn't have an ability to get even to the Civic Center to get tested. So we mobilized a team. I repurposed a van from MarinHealth Hospital, and I drive the van every day, or at least 4 days a week. We stock it with our portable toolkits and testing kits. And the day starts with a phone call in the morning, a huddle phone call with the Department of Public Health and our Kaiser Permanente team members. And we go over who's heard what cases have turned positive or where we think there are outbreaks. And we determine our test plan. Usually we have that information 2 or 3 days in advance, and we can determine where we should go. So half of the time I'm in the skilled nursing facilities or those residential care facilities that my colleague Dr. Miller talked about. And the other half we're out in the community where there are outbreaks or requests to come and help with testing. And we knew fairly early on that the Canal region had a high prevalence of disease, and we wanted to be able to go in and help provide testing and to be able to give them guidance. So I'm half in the residential care facilities and half in the community doing testing.
Awesome. And where are there other locations that you, I know you mentioned the Canal, are there other locations that you visit that are outside of that skilled nursing environment?
Yes, so now we have a huddle phone call with Dr. Willis on Wednesdays where we go through epidemiology charts and decide where we really feel like we should do more targeted testing. Sometimes it is in commercial businesses. We've done the testing at the Marin Sanitation. We've done testing at grocery stores. We've done testing both at, that's my team. That's my Canal team. There we are at the Canal Alliance. We're at the Canal Alliance every Wednesday and Friday. We've formed an incredible partnership with Omar at the Canal Alliance, and he's been an incredible outreach point person to get people to show up to get tested, and then we provide care. We partnered now just recently this past week with Marin Community Clinic to provide follow-up care. So anyone who has questions, who is feeling symptomatic, we make same-day appointments with Marin Community Clinic. Yep, so that's our whole setup there. The blue tents are the follow-up clinics in Marin Community Clinic. And the first 2 tents are where we take in people and register them and then test them. And we've gone to schools, we've gone to Nevada, Marin Community Clinic campuses, Marin City. We do a lot of coaching and telling people that it's really not that bad. We try to play music so the atmosphere is fun. We have stickers and tattoos and treats for the kids who actually go through it, and then we have fun. So if we get a dance break, if we do a job well, we get a dance break. That's us at a residential care facility. That's our team. We started a college student intern program also. I have 5 college students who are working with our team this year, and they've been incredible assets to the team. They're getting an experience of a lifetime. And so those are 2 of our college student interns.
That's awesome.
Yeah.
That's such a great experience for them as well. To be able, I mean, who knew these college students entering nursing to be able to have, well, first of all, pandemic, not a great thing to wish upon the world, but in terms of that learning environment, truly a once in a lifetime opportunity, I would imagine, from that perspective.
It's better than in-class learning.
Well, let's go back to that testing process that you were walking us through. Once you have gone through that process of collecting the samples, and thank you for providing some behind the scenes photos, not only of your team, but the testing and process. Where do those samples go? How do they get there? And typically, what is that time frame?
So the samples are collected. We have different labs. We have 2 or 3 labs where we determine that morning who's going to be able to take our samples. It's a lot of the labs, as you've probably heard in the state of California, are at maximum capacity. So every day it's a little bit of day trading for how many samples you can send to which lab. Once we make that determination, we take our little portable styrofoam coolers and our test kits, and we go out on site and do our testing, and then we methodically label them and roll them up and keep track of all the demographics of the people we're testing and send them off to the lab. So depending on, I feel like I'm now in the canal giving my speech. Depending on the lab, the results we hope take 3 to 5 days. Usually if they're positive, they do come back earlier. So we have the capacity to contact a positive sooner to be able to give them advice, guidance, and follow up. But usually 3 to 5 days, we like to think 5 to 7 sometimes, depending on how backlogged the lab is.
Yeah, we've heard the same. What do you think is the most important thing that people should know about COVID-19 testing?
Do it. If you definitely, if you are symptomatic, I think it's not as scary. I think people have a lot of fear and trepidation that it's going to be painful. It's not fun. It's no worse than getting water up your nose. If you've ever gone upside down in the water in a pool and you've gotten water up your nose, that's about the feeling. And it's just a few seconds of a little bit of discomfort. I think that's probably the biggest thing that people have fear of, is that it might be painful. It's not fun, but it's not horrible. And I think if you have a concern, if you feel like you've been exposed, if you feel, certainly if you're a frontline worker, you should be getting tested, and it's just for the good of the community.
That's a great point. The pop-up testing locations, you gave us a sample of, in terms of the variety of locations. How are those locations selected? Do you select them at random, or is there more to it than that? Such as Canal Alliance and some of the others.
Yeah, it's never at random. It's where we have determined based on our positive results that come in. Like I said, with the conversation with Dr. Willis, we do look at the epidemiology maps and decide where we've found a high prevalence. We decide we need to go and test further to make sure that we're really making, that we're taking precautions to make sure that we're keeping that community as safe as we possibly can. So it's not random, and obviously if there are any residents in the skilled nursing facilities, that triggers where we go also. So we have kind of a 2-pathway determination for why and when and where we test.
Great. Well, with that, is there anything else that you would like to add to kind of wrap up and kind of make sure that you've said all you want to say about the mobile testing effort that's underway and all that your team has been doing?
I think that I would add that it's been a really great collaborative community. I've been really proud to be part of Marin County, where we've been able to collaborate with what would be considered different insurance models or practices, and to actually be uniform in our thinking and our partnership. We have a great test kit exchange. We talk about that if we're on a facility at a site where there are Kaiser patients and our patients, we carry their test kits with us, and we just decide, yeah, we're here, we'll swab all your patients, or they're somewhere else and they'll swab our patients. And it's just been really nice to be unified in trying to keep our community safe. And, I've said before that the virus is the enemy, not any other, there's no other competition. It's really just trying to keep our community safe.
Profound words that could be applied to many things in this pandemic. Thank you, Dr. Lowe. Well, for those of you that are watching and maybe tuned in a little bit late, this is our community conversation event hosted by the County of Marin and Marin Health and Human Services. We are joined today by Dr. Matt Willis, Marin's Public Health Officer, Angela Nicholson, Director of Marin's Emergency Operations Center, Dr. David Miller, an infectious diseases practitioner at Kaiser Permanente, and Dr. Elizabeth Lowe, Medical Director for Marin Health's Mobile Care Unit. And now before we open up to Q&A, I again want to thank the many, many people, I think it was 95, who submitted questions in advance of the event. As you can imagine, we're not going to have a chance to get through all of them, but we did our best we did review all of them, and we did our best to curate them into themes so we can knock out as many as possible. If you're unable to, if your question is not answered, remember we do have our call center available for non-medical COVID-19 questions. It's available Monday through Friday, 9:30 to 5 p.m. And that's available at 415-473-7191. And with that, let's get started with some Q&A. So in light of the president's most recent directive, are Marin's hospitals going to bypass reporting COVID-19 data to Marin's Department of Public Health? And also, will Marin's hospitals continue to report COVID data to the CDC's National Healthcare Safety Network? Starting off with a bang, who would like to tackle that one? Dr. Willis?
Why don't I start with our hospital representative to see, are you going to stop reporting to so I assume this refers to the president's announcement that all the data is going to the White House.
Yes, that
Okay.
all hospital
So let me
data will
ask
surpass. Yes,
Dr. Miller and Dr. Lowe, are you planning on sending all of your data directly to the White House?
I will not be bypassing the Marin County Department of Public Health. I think we've got a wonderful system here, and I think we're going to keep using it.
I agree.
Thank you for saying that. I had hoped that would go without saying, but it's good to hear it articulated. Yeah. So for the community, I think yes, we have robust systems and I think it's part of what some of the data you saw today. That the data begins in our community. It's through the testing that Dr. Lowe articulated. It comes in. We get the testing results. We reach out to people. We see what's happening in the hospitals. We're tracking our mortality. So we have control of the data because it begins at the grassroots. It begins here. And so we will be using that data ourselves to guide our strategies as we always have. And that data points to the state, California Department of Public Health. Also, we have a strong relationship with, and the data goes there for statewide understanding and strategy and resource allocation. So I don't see the political aspect of that articulation from the president as being a threat to our own access to the data that we need.
That is excellent to hear. And on behalf of the many, many Marin residents who very carefully study our data and surveillance page on a daily basis, they thank you as well. Now we've talked quite a bit about testing. So let's move over in that direction and talk a little bit about the availability of testing. That's been a question that's come up quite a bit. Is testing readily available? Who can be tested? Is it free? And we talked a little bit earlier, Dr. Lowe touched on that results component. But what's the real story about testing? So Dr. Willis, would you like to start that off, or I will allow you to defer to one of your colleagues if you so choose?
I can start, and then others can chime in. So we recognize that testing is one of the most important tools that's available to us. We are, and that value, I think we've been aggressive in our approach from the beginning in Marin County to make sure that we had the testing resources that were available. We have a very high per capita testing rate compared to other counties. And we still recognize some areas where we would like to do more testing than we can. The fact is that we're in a statewide state of scarcity with regards to testing resources. And so we still need to prioritize testing for certain situations and settings where it's most important and highest yield. And so that's, for us, just to be very clear, the criteria are, as Dr. Lowe articulated, people who are having symptoms consistent with COVID-19, people who have been informed by the health department that they may need testing based on a contact investigation and maybe have been in close contact with a known case, people who are in more sensitive occupations, who are in regularly public-facing work where if there was an infection asymptomatic, it might represent a threat not only to themselves but to people around them. And then people who have risk factors for more severe outcomes if they do become infected, people of older age or people with comorbidities. And so our new testing site that we're establishing that Angela Nicholson mentioned is going to have kind of a clearer gating criteria for when people go on to register for free testing online. We'll guide them through some questions about whether or not they meet those criteria. Because really right now, unfortunately, we're still not ready to test the worried well, I would say. People who are just seeking testing for sort of that peace of mind and reassurance. We really need to continue to still reserve our testing resources for those people that have a higher risk so that we can intervene as early as possible on cases to make sure that they're safely isolated and the people that they've been in contact with are quarantined.
So if someone does not meet that criteria that you just mentioned and they're concerned, what should they do?
I would suggest they reach out to their medical provider. Another, I think, important theme here is that COVID-19 in the early days, March, April was really, it was a public health crisis. It was viewed as a public health crisis, and public health infrastructure was really kind of the first to mount a response in amazing partnerships with our healthcare providers, as Doctors Millard and Lowe have talked about. But it is now becoming more and more routine healthcare. COVID-19 is going to be with us for potentially, forever. And certainly, for the next year will be an important theme around our health as a community. And so our healthcare providers are stepping into kind of a more complete role in a variety of different ways of supporting us, especially in making sure that testing options are available. So virtually all of our healthcare providers have ramped up their own capacity to do testing. And so I would recommend anyone who doesn't meet the criteria for that smaller subset of public health available testing to reach out to their medical provider and discuss it with their physician to determine what their needs might be and what would be the best way to meet them.
There's reports that there's a test on the market that gives results almost immediately. So in light of the lab backlog that Dr. Lowe described, why couldn't that one be used in those areas of high risk, and especially with those who meet the criteria and might be waiting on results?
Yeah, do you either of you want to talk about kind of the benefits and liabilities of the rapid testing modalities?
Sure, Dave Miller. So I think the viewer is referring to the ID Now from Abbott. It's a 15-minute test. Unfortunately, the sensitivity is a little bit worse, meaning you can get false negatives. So that is a limitation of the test. But even those tests aren't necessarily available. So any test has limitations. You need certain reagents, cartridges, and supplies to get those tests done. And so I think no matter how many tests we have, we want more, and so everyone is doing their best to scale as much as possible. I think Kaiser has, I believe we have the biggest internal lab in the country, and with the amount we're trying to test and grow our lab capacity, we're doing over 6,000 tests, well over 6,000 tests a day. We're still being strained, and so I think everyone wants to provide these tests and as much as possible, but every testing system has limitations.
Great, thanks for that explanation.
Can I just add something to that really quick, which is that you're trading. Sometimes you're trading accuracy for speed, and that's unfortunately with the Abbott test, the rapid tests. You get a faster result, but it's less likely to be an accurate result. And there are some situations where that might be useful, but in most situations, it's really hard to, especially when you get a negative result and you're not exactly sure that actually means the absence of infection. that's a major limitation to those much more rapid modalities.
Great addition. Thank you for that. And I do want to remind our viewers, if you are interested in reviewing that criteria that Dr. Willis mentioned and review other information about test sites, including locations, as well as a frequently asked questions section all about testing and possible exposure, you can find that online at coronavirus.marinhhs.org/testing. All right, let's shift gears and talk a bit more about hospitalizations. Dr. Willis, previously advised Marin County that we should prepare for a surge in COVID hospitalizations starting in July and into fall of this year. So what are the current projections over the next few weeks and into the early fall for new infections, hospitalizations, ICU ventilator beds, and demographics subject to major identified variables for Marin County as it relates to hospitalizations?
Yeah, I can answer that from a public health standpoint, but I'd love to hear from our hospital partners to hear how they're thinking about surges within those settings as well. So can I go to Dr. Miller or Dr. Lowe to start with that?
Sure. I mean, of course, you're asking to predict the future, which is very challenging. And, with the pandemic, you're either alarmist or you're too late. And I do think the current trends, and I'm sure Dr. Willis can elaborate on this, the current trends are very concerning about the way things are going. And the difficulty of mitigating spread in people who have to go to work, who have to live in denser living settings, who have to carpool to work to make ends meet, makes the situation a bit more challenging. Does that mean there's still a lot of unpredictable variables here? And so I'm still hopeful, and where this will peak and so forth, I don't know. But those are my concerns. Certainly, we could see some ongoing surge certainly in the weeks to come, and potentially in the months.
I would echo that too. I have as part of my call right before I get on our group call, I get the hospital census for how many COVID positive patients are in the hospital, and it's definitely been up in the last month compared to the first 3 months, and all of our testing that we're doing in the skilled nursing facilities is markedly up, which to me it is concerning, because it was fairly quiet for a long time, and I think we were really doing a great job, and it's just reflected kind of the lifting of sheltering in place and lifting. I think people I always thought, let's see what happens after Memorial Day to see what happens, because I think that's when people kind of liberalized their sheltering in place, and we have seen the data play out, I think.
Yeah, and so I mean, the modeling that I've shared before, I think that was alluded to, did forecast surges in July, and so we're looking very carefully. Obviously, those forecasts are based on case counts. One of the reassuring elements is that while we have seen spikes in cases, it is, as we said, it tends to be in workers and then their family members. So it's a younger cohort of individuals that we're seeing as being contributing to those recent spikes. And their hospitalization rates, the likelihood that someone in that group becomes hospitalized is much lower. So we haven't seen the rate of hospitalizations that would correspond to the increase in cases that we might have expected. We are seeing more people in hospitals, but again, even a week ago, we had, I think, 35 or 36 people. Now it's 29. It's been bouncing in that sort of high 20s at a relatively stable rate. So obviously, we can't control the number of individuals who become sick enough to require hospitalizations. The only mechanism we have over that is by reducing transmission, reducing cases in the first place. And so ultimately, this all comes down to our collective responsibility to do everything we can to reduce hospitalization rates, to reduce transmission, which translates into reduced hospitalization rates. Fortunately, our hospitals have had plenty of time because of the early flattening in the curve to really prepare for surge. And I think hopefully this conversation illustrates how great our hospitals are and how great our partnerships are. And we have, each of our hospitals has capacity beyond what their current, bed count is for surge as part of the surge plan. And then we have an alternate care site that's established near the Civic Center with 25 beds now that are ready to go. That everything is in place. It would get staffed if we started to need to fill that. And that can be expanded up to 80. So we have our surge plan is sound. And fortunately, we haven't needed to invoke those plans yet.
That's good to hear, thankfully. Related to that, what is being done to prepare for winter impacts on COVID-19 transmission? And on a related note, what is being done to provide safe access to obtain those seasonal flu and pneumonia shots that we're going to be advised, or we typically would advise people to seek in the fall?
You want to take that, Liz?
What I can say is that I'm definitely immunizing my patients. I'm recommending for my vulnerable older patients getting their pneumonia shots, getting their influenza shots when those come into season, because the last thing we want is all of these things happening at the same time. So to the extent that we can reduce any other infections and all those diseases that used to exist before COVID-19, we still need to take care of all of those. I've had my patients, I do a lot of video visits, and then I have them just come in almost for a drive-by for an immunization. They pull up into the parking lot and we give them their immunization so they don't have to have any exposure. And so really that's what we're doing. Specifically to COVID-19 precautions in the fall, I'm still so focused on the summer that I'm really trying to stay in this moment, because I feel like if we do our job well now, the fall will look better. I'm not kicking the can down the road. I'm just trying to be mindful of where we are right now.
Yeah, and the county is, we prioritize flu vaccine every year. We have free flu clinics. I hope that this year, no matter what we say, every year we're promoting this. We visit schools. We do vaccinate. We do mass vaccinations. And the uptake is, in the best years are 60 to 70%. And I think there's a lot more awareness across the community now of how important this is, and how much of a threat these respiratory viruses can be. And obviously co-infection between COVID-19 and influenza would just compound the risk for a bad outcome. So this is the year to get that flu shot. And when we get the shot, when it's available, we're going to be doing the same promotion we do every year. And we're hoping we finally get that 100% uptake we've always wanted.
Yeah, I think at Kaiser, we're looking at a number of different angles and including probably an earlier initiation of the project to get people vaccinated, and looking at different ways to piggyback this on the different workflows that have been created in adjustment for the realities of the pandemic. In addition, we're looking also at dual testing. There are some new test products that are coming out, which test for both the flu and COVID, and we're identifying the good candidates that we could utilize. Of course, the concern is people may be sicker with both viruses, and or at least confused that they may have COVID when they have the flu. Neither are pleasant. And I'm still hopeful, and this is my non-professional opinion, I'm still hopeful for a mild flu season due to our social distancing.
I think we all are hopeful in that regard. All right, so I think we are about out of time for this session. I do want to be mindful of our doctors' times, not only because they've undoubtedly worked a very long day, but they likely have other places that they need to get to. So thank you so much, Dr. Miller and Dr. Lowe, for joining us today. It was a pleasure to have you both on our panel. And thank you again to Angela Nicholson and Dr. Matt Willis for providing us with a really informative update as well. And I would like to thank you, all of you that are watching online. This event was recorded, and so it will be available for an instant replay access on our Facebook page, and will be also available for non-Facebook subscribers on our YouTube page tomorrow morning. So do keep an eye out for that, a very shareable link, and we hope we do share it widely. Again, remember, you can access all of the latest COVID-19 data and information on our website at coronavirus.marinhhs.org. We have a very thorough FAQ that Dr. Willis mentioned. It is keyword searchable. So questions you may have, from testing to exposure to where to wear your face covering, are all covered in that FAQ. So go check it out. If that doesn't quite answer the question you have, remember, we do have our call center operational Monday to Friday, 9:30 a.m. to 5 p.m. And those call takers can be reached by calling 415-473-7191. Again, thank you to our participants. Thank you to all of you at home for watching, and stay safe, Marin. We'll see you again soon.
Thanks.
Thank you.